So before I start my comments, I'd like to acknowledge and thank a few people in the audience who are particularly special to me. My parents, Zeke Jr. and Shirley, my amazing daughter Sophie. Not with us today is my son Matthew. He's in midterm exams at Miami, but he's in my thoughts. And then obviously my amazing and lovely wife Erica, who's been a partner of mine on this journey since I was in medical school. I'd also like to acknowledge my very first, believe it or not, faculty in interventional radiology, and despite his spry age of 90, Richard Fisher was kind enough to make the trip to be with us today. Dr. Fisher, thank you. But I'd especially like to thank our president, Dr. Alda Tam, because Alda is seeing and sensing what I think a lot of us are seeing and sensing, is that things just feel different. The pressures around us, the public policy changes and how they're affecting the practice of interventional radiology feel different and are worthy of discussion. This is my post-fellowship policy universe. 2005 Deficit Reduction Act, the first unilateral reduction in imaging services, advanced imaging services, including CTA and MRA. 2010, the Affordable Care Act, the first major policy change since the inception of the Medicare program. 2015, the Medicare Access Chip Reauthorization Act, which codifies the quality payment program going forward. 2020, a challenging global pandemic and a rapid emergence of digital technology. Here's where we are, but if you'll notice, it feels like things change about every 5 years. Sort of activity, spike, activity, spike. So as we're going into 2030, I think it's relevant for us to think about where interventional radiology is and where we can contribute. And I see a number of challenges. So I think these are, among many, probably the big three. This move towards greater consolidation, both vertical and horizontal. This move towards value-based care. And I think the one that's on many of our minds, which is the rapid emergence of digital health and artificial intelligence. But as daunting as those tasks are, here's the good news. I will make the argument today that interventional radiology is the best positioned specialty to help solve today's healthcare challenges. Your first reaction is, well, that's great, that's good to hear. Your second reaction may be, oh my, that may be a lot of responsibility. We need to think about this. We need to discuss this. And how do I make that belief? Where does that belief originate? Well, it's certainly who we are. Scott Triotolo was kind enough to let me borrow this diagram, which he showed during his 2016 Daughter lecture, having borrowed it from John Kaufman in his 2012 lecture. He explained it within the context of our competitive advantage based on imaging, technical, and clinical skills. I would make the argument that these same skills make us particularly relevant within the public policy space. But to really understand why we have so much potential to contribute and so much potential to be successful is to look at who this lecture is honoring today. Charles Theodore Dotter. I direct you to Tim Murphy's excellent 2018 Dotter lecture for an incredible description of Dr. Dotter, his talents, and his contributions. Really probably should be and is required reading for anyone in our specialty. Tim was kind enough to share this with me. According to Tim, this is one of the first angioplasty patients that Dr. Dotter treated. And if you look at the requisition from the vascular surgeon, it says, visualize, but do not try to fix 3 exclamation marks. Oh, and underlined, by the way, it was probably in red. Dr. Dotter goes on, treats this patient. Just to orient you to the angiogram before you, this is the femoral circulation, this is the thigh. He does an angioplasty of the deep circulation, visualizes the superficial, and it's surgically corrected later. Dr. Dotter used to like to quip later about this particular patient because it was actually his percutaneous treatment that lasted and maintained the viability of this patient's leg, whereas the surgically treated lesion failed. And it wasn't enough for Dr. Dotter just to evaluate this case control study, if you will, by asking his patient to walk down the hall or maybe how many times you can walk around the block. He actually joined that patient and hiked to the highest peak in the state of Oregon, which is Mount Hood. So most of this is happening around 1964. Things are looking pretty good for our specialty. As we're moving forward, let's kind of think about what the potential lessons which we can learn and ask ourselves if this is enough to carry us forward. Unquestionably, to be in the in crowd within Dr. Dotter's universe, you had to be independent. dare I say maybe disruptive, but that independent spirit, that realization that what he was doing was significant and what he was doing was real, and how strongly he believed in this, his calling to be innovative. The word innovative, innovation, some derivative of that already has been mentioned several times today. It's who we are, it's what we do. But there's a third term, and before I show it, I'm actually going to define it, because it's somewhat provocative. Was he so strongly believed in the innovation that he could bring to patient care that it was impossible for him to be satisfied in his quest for knowledge, in his question for innovation. He was simply insatiable. He pushed it, and he pushed it because it was what he believed in. That's the origin of our specialties. I mentioned that's around the mid-60s. Things are going pretty well for interventional radiology. We actually have our first meeting of what is today the FSIR. Key Largo, Florida, 1975, starts the clock that what is the 50-year history of our society and what we're celebrating next year. But something happens between 1975 and the meeting which occurs in San Diego, California in 1987. And that's the following. 1986, the Florida meeting had 109, what we would think of today as fellows. It was a closed membership. It was a relatively small society. 1987, the membership is open, more than 500 members. This massive infusion of 400 new members, all of whom practicing interventional radiologists, but it was a new talent pool. It was a new group of interventional radiologists who came in and said, look, we think that we can do what we do, we believe in what we do, but perhaps we need to advance the specialty even more and perhaps even faster. This group was politically savvy, this group understood public policy, and this group understood what was necessary to do what we needed to do to bring our specialty to the forefront of patient care. A couple of other events happened during this really remarkable period between 1987 and 1992. Our journal is born. JVIR was first a four-part series with the RSNA, but later we had its own single standing. In the spirit of independence, Gary Becker likes to talk about designing the JVIR and talking about what color it was going to be. And at that time, there was lots of discussion about making it red. Makes sense, right? Vascular, blood, red would seem to make sense, but Gary didn't want it red because he didn't want it referred to as the red journal. In the same way we have a gray and a yellow journal within radiology, he wanted it to be referred to as the JVIR, and that's what it is to this day. Around the same time, a number of events occurred as well, which were hugely significant for the advancement of our specialty. We get accreditation for our fellowship programs. Shortly thereafter, CAQ status with the ABR. Our meeting goes from being a gathering of fellows to having a scientific sessions and having abstract presentations. What is today the SIR Foundation and what is today the SIR PAC are born. And all of this that happens between around 87 and 92 is hugely relevant to us for the following reason. When you talk to people that spend their time like me in the advocacy world, going and talking to legislators about laws, talking to policymakers about regulations, and doing that at the federal and state level, you have to have a product that's meaningful. You can advocate all day long for something that just doesn't have value. But we had the research value. We had the scientific value. We had the educational value. We had a product that we could take to lawmakers and policymakers and have them help us to expand it. And it is a very good thing that we did because things start to change within 5 years of that meeting. Around 1990, this is William Shao. William Shao was at the Harvard School of Public Health. William Shao is creating a system to completely revamp how physicians are paid within the Medicare physician fee schedule, and secondarily private payers as well. It's a complete change in how physicians are paid for what they do. To understand how this evolved and understand why it was relevant to us is just sort of look at the two sort of most basic steps, if you will, in payment for what we do in IR. You got coding and you got payment. When we talk about coding, it's the ability to describe what we do with CPT codes. 36200, catheter in the aorta. But there are a number of moving parts at this time, a number of discussions both within the House of Radiology, but also within the House of Medicine. There's a push to have what are called complete codes. Imagine a mesenteric arteriogram. The complete code might say mesenteric arteriogram. But we in IR came forward making the argument, making the point that we think it should be component coding. Because what we do is different. It's more complex than a simple mesenteric arteriogram. We want to be able to code for the selection of the celiac and the SMA and a third order branch and perhaps an embolization. We wanted to have accurately represented what we did, certainly for billing purposes, but also for health policy research, resource use, epidemiology, to capture what we did, and we were successful in that regard. When we talk about the payment side, the means to get paid at that time was usual and customary. As you're thinking about where we were going to find ourselves within an evolving system, which would become the resource-based relative value scale, once you have those codes, you might ask the question, where do we want to find ourselves on this scale? How do we want our services to be described? Our leaders at the time came forward and said, we want component coding, and we want to be described with procedural specialties. We want to be described in the same place with the vascular surgeons, the endoscopists, the neurosurgeons. And it wasn't an obvious change for us to pursue. There's a lot of want, not just for the complete coding, but also to have us in sort of a separate, specific radiology section. But we were successful in getting those codes. The component coding system was born. When we went to the valuation piece, this is kind of how this works. Alda was kind enough to mention that I chair the group that oversees this process. It's 29 physicians, all extremely talented and extremely committed to what we do. But when you're coming forward to the RUC and you're coming forward with your services, the job is to find where you're going to reside on that scale. We had component codes. We had codes described in the surgical literature, surgical part of CPT, and we were successful in ensuring that we could bring forth accurate descriptions, robust valuations to ensure the economic viability of this specialty, which has carried us for the last 30 years. But there's a third piece that was a real credit to what we were able to do from a public policy perspective for interventional radiology. We knew how to work within the system. We were smart, we understood the dynamics at play, and we knew that we had to work with policymakers within the system. Around the turn of the decade, there was a very important meeting that was taking place, Andrews Air Force Base. All the leads from the White House, all the leads from Congress were getting together and making a budget reconciliation process, putting it together. FSIR brings in a lobbyist named Fred Graff. Fred Graff is ex-military, had a lot of friends at the security gate. Fred was able to get into the meeting, meet with those staffers, and as a result of those efforts and our leadership's efforts, around the turn of the decade, we are recognized as an independent specialty, able to bill and able to bring forth radiology, interventional radiology services. Let me bring all this together, because that was a lot of information, that was a lot of achievements. But what we did from 87 to 92 is nothing short of remarkable. We brought forth component coding. We have surgical and radiology coding. We've got meaningful valuation. Oh, and by the way, we're recognized as a specialty. The leaders we all know the giants in our field, and we should. But I would argue the giants of our field from that period of time were Barry Katzen. Barry tells a story how when he was applying for fellowship when he was a closed society, that he was rejected twice. He was finally accepted the third time. He was the president during that transition. Other names, Gary Dorfman. Barry describes Gary as the tip of the sword, whereas Barry was the one that would travel from Northern Virginia, where he was practicing, to meet with lawmakers and policymakers. Irena Van Breda, I would say the same thing about her. Mike Pentecost, Ernie Ring, among others. We knew what we had to do, we believed in what we did, and we brought that forward for all of the right reasons. We can stop now and feel probably pretty good about what we've done and where we are, but I've already mentioned we have some challenges coming forward in 2030. Let's come together, let's think about where we are within this space. I showed this earlier. I briefly want to talk about the first two, and I want to do a deeper dive on this third, because this third one's on many of our minds, and it's hugely relevant for society and for us as IRs. At the consolidation level, Alan Matsumoto in his 2019 daughter lecture talked about this rapid vertical and horizontal integration and consolidation occurring within our healthcare system. Every major payer in the United States is completely vertically integrated, from insurance, PBM, pharmacy, facilities, hospitals, and hint, hint, by the way, physician practices. Value-based care. Bob Curlin did an amazing lecture in 2015 during his daughter's speech talking about this movement towards quality payment, the quality payment program, etc. The changes we're seeing in this program, it's becoming a little bit more private practice or private insurance focused. We're seeing more interest from that group. We're also seeing this more driven by primary care than specialty care. But what it means to us is, as these value-based care models grow and proliferate, if you're on a per payment per month policy for a number of beneficiaries, what are you trying to avoid? You're trying to avoid hospitalization, you're trying to avoid procedures for all the right reasons. Preventive care, keeping patients out of the hospital. But it's relevant for us because that's kind of what we do. So for us, as these models proliferate, we need to think about how we can advocate for ourselves, how we can bring forth our innovative, independent spirit to represent ourselves within these models. But this is the one I want to do a deeper dive on. Digital medicine, digital health. And we knew this was coming. A group of us around 2016 saw this was coming into physicians' practices. Got together, there was about 15 of us. No surprise, IR was well represented. Kathy Kroll was an original member, as was I. There were past CMS officers, past FDA. We had a vendor community. And we came together and said, what is this going to mean going forward for medicine? Digital health, remote therapeutics, remote patient monitoring, digital therapeutics, and the like. And as this is coming forward, we're sort of asking ourselves, as we're getting ready for the next chapter, excuse me. It's a good thing we were thinking about it. To understand how IR is going to be affected by artificial intelligence, let's venture outside of the IR and even the radiology space for a moment. Because in 2018, this product comes along. This product called IDXDR. So what this product does is it is a camera that takes an image of the retina. Based on that image, it makes the determination whether or not there's pre-diabetic change. You say to yourself, doc, that's great. Ophthalmologists have been doing that for decades. What does that mean? This product was completely trained and functions autonomously with no human interaction, no human health whatsoever. It is a true artificial intelligence system. And it gets approved by the FDA in April of 2018. It was one of the first products to have that designation. To be fair, Viz.AI and its large vessel occlusion system was around the same time. But it was pretty significant because the FDA is now saying that software can potentially function as a medical device, the same as any device we would potentially place in our own practices. Like us with component coding in the late 80s, the ophthalmologist wanted to be in this book, which is a really cool place to be, because you want your services described, you want your services recognized. CPT editorial panel meets May 2019 to discuss this new code, this autonomous diabetic retinopathy application. No surprise, IR is well represented. I already mentioned Kathy was in the room, Dan Pikus is on the panel, Tim Swan, Matt Hawkins, a number of us were there sort of pondering this question: where do we put a machine learning algorithm into the book that describes what physicians do? Someone raises their hand during the panel discussion and says, you know what? We've never used the word autonomous in this book because we never had to. So a group of us got together and said, we probably need to think about this more deeply. We put this paper out shortly thereafter sort of to describe the work performed by machines. And it was a little controversial because we're humans. We do work with the human touch. That's who we are. That's what we do. But now we're talking about describing work done by non-human entities, aka machines. We thought about it carefully. This is the categorization that we proposed. It's in the CPT book to this day. Assistive, Bing, Bing, doc, you might want to look at that. Augmentative, Bing, Bing, doc, you want to look at this and it might be this. And then the category of autonomous where, doc, thank you, but I can do this on my own because I'm a machine and I'm capable. It was a It's significant for us for a couple of reasons, because we are going to bring forth innovations in AI, in IR, and when we do so, it's going to have to, for the most part, conform to this structure and this taxonomy. Those codes come to the CP, or to the RUC, to my group, and instead of IR codes like we had done 20, 30 years before, now we're having to deal with the AI codes. Think about what's the value? What is an AI code, an AI system, an AI application? What does that do to physician work? Like, where are we on this spectrum? Because the first one that's there sort of sets the baseline, the foundation. Everything in IR that comes in later from an AI perspective is going to have to find itself on this scale. I'm very proud of what we do at the RUC. I think we represent well how physicians think about what they need to do in their practice. But a group of us got together and said, let's think about this more broadly. Let's think about how artificial intelligence can be valued in a reimbursement framework within the broader healthcare universe, societal universe. I won't go into the details, but we were able to build in a lot of principles that go beyond simply resources. They go on beyond simply the quality of what we do. When we looked at economic factors, we looked at supply chain, we looked at factors like equity, health inclusion, Pareto economic principles where you give to one body but not to another. And I share this because one, it's relevant for AI, but two, it's potentially relevant for us because remember, I showed the consolidation piece and now we have to think about how we are going to prove and validate our value within larger bundled systems of care. Potentially one model, certainly a potential to give us ideas for building additional models around what we do. So I've introduced AI. So let's kind of look at this at a sort of a more foundational and more simple level. So when we talk about an AI system, all we're really doing is asking the system to do something as well or better than a human. I mean, that's essentially the core of what AI is. So how do we train a human? Well, we do what we're doing right now. We do education. We do your upbringing, your values, your experiences. How do we train AI? Data. That's the element. That's all we have. So AI and data matters. For us going forward, it matters. And once again, no surprise, we're right there ready to lead this charge because we've done it before. Let's go back to the late 80s. Let's kind of think about the emergence of computed tomography for CT. I'm old enough to remember learning CT when it was 16 images on one piece of film and an alternator kind of looking at it like this. In those days, it didn't really matter if this CT looked like that one, specifically as far as the data elements. But once we went to soft copy, once the radiation oncologists were saying we need a little bit better standardization, and once the IRs were saying we need more standardization of data to inform the interventions we're performing, we sort of had to do something. We had to create a system, which was later called the DICOM system, whereby the DICOM system of medicine could standardize data elements for CT across multiple scanners, multiple geographic locations, even multiple countries. And it's still in place in its third or fourth version today, informs workflow in HL7 and FSIR, and is a system and unquestionably a credit to who we are and what we've been able to accomplish. Hey, we're IRs. I mean, that data stuff's great, but bring this into my IR suite, bring this into my universe. Wisconsin's been mentioned several times during the session already today, so I'm going to take us back to Wisconsin to show some data here. Scott Reeder was kind enough to share this imaging with me. Scott Reeder is the chair of Wisconsin. If you remember, 2021, Zeev Haskell's daughter lecture, Cowboy Myths, Cowboy Dogma, sort of talking, and he mentions hepatic venous portal gradient, 12 millimeters, like that's the number. Remember, Zeev sort of shared that with us. Well, we know that most patients that have esophageal bleeding all have a gradient greater than 12, but not all patients that have a gradient greater than 12 bleed. Like, how do we make that differentiation? Well, endoscopy, look, potentially do an intervention, test that gradient, but what if we could do it with imaging? What if we could do it with 4D MRI to stratify the risks of variceal bleeding? 4D MRI is basically phase contrast MR. You do it in 3 different planes and spatially and temporally relate it to the blood flow in the organ of interest. Works really well in the heart and the coronary circulation. And according to Scott and his colleagues, is going to potentially work very well in the liver. The physics, the clinical application is interesting. But Scott and I are interacting about this. we both agree that what may be really important here is our ability to standardize the data coming from these studies. You do it because you want to be able to make comparisons within your practice, within your geographic domain, even internationally, and we're not there, but we have that opportunity. Oh, and by the way, hint, hint, some of this data may be used to inform future AI systems to make these determinations regarding patients non-invasively, even retrospectively on MRI scans that have already been done. I know you're still thinking, we're procedural docs. AI is not going to come into our procedure room because we use our hands, we use our minds, and that is a huge credit to what we do. Johns Hopkins puts out a paper early last year where they describe laparoscopic surgery without human help. They completely trained an AI system with visual and mechanical parameters around laparoscopic surgery, did it on 4 patients, luckily animal models, and claim that they were able to do it better than a human, better than a surgeon. And if you talk to surgeons about sewing bowel, they'll tell you it's one of the hardest things they do. It's friable, it's difficult, and if you mess it up, we know from our own experience in IR, the complications could be significant. This is one of my IR suites in San Antonio. Let's fast forward. Let's go forward to 2030. Let's imagine, or even beyond. And I'm walking into my suite. This is the age of AI. We've done everything I've described. We've done it well. Walking into the room, I've already, from a pre-procedure perspective, been able to bring together all of that patient's genomic data, all of that patient's radiomic data, the ability to look at imaging and pull out clinically significant data elements that even the human eye can't detect. Oh, by the way, we've been able to look at the patient's entire medical record. We know going into the procedure the predictive value, potential complications of what we were about to do. We start the procedure, we're humans, we're ready to work. Along the way, we have clinical decision support regarding what to expect from the vessels, how to better select them. If we're really lucky, those cool radiation glasses that we use have a small sort of visual field on them that tells us exactly how to make the next selection. Alerts us to physiologic parameters that may tell us that the procedure could go better than it is. And the post-procedure management is affected as well. It's hard to talk about AI with sort of not bringing up the topic of the moment, which is large language models. There's a lot of them out there. The ones we hear probably most frequently is sort of OpenAI and ChatGPT. You know, in the spirit of Zeke's kind of cowboy myths and cowboy mantras, this is the Wild West. I can tell you from experience and being in these discussions, the FDA has no idea right now how they're going to manage this. Because we've gone from infer, detect, to understand, generate, interact. We're going from a universe where it's no longer, hey computer, go find some information. Now it's, hey computer, go create some information. Convolutional networks to transformers. I mean, it's happening so fast. It's happening in real time. But the good news is it's our chance to influence that. It's our opportunity to bring that forward in a way that's beneficial to patients and beneficial to our specialty. It's a lot of information. Let's kind of let me bring this together. Because there's a lot for us to think about, and there's huge opportunity here. Over the next 5 years, as we face these challenges, let's ask ourselves if those sort of founding principles that Dr. Dotter and his legacy instill in us still apply. And if they do, how we might want to evolve those. The independent spirit. I believe in public policy. I believe in advocating on behalf of physicians. I also believe in balance. I believe that within public policy there needs to be balance, and right now I'm worried that the balance is moving away from patients and physicians and interventional radiology into a space where it's becoming overly burdensome. So even though we're having this debate regarding consolidated systems and independence versus interdependence, I think it's a time for us to maintain our spirit and not be shy about moving forward in policy circles and telling them who we are, what we do, and why we believe in what we do, because this is who we are, we're innovative. I don't have to tell this room about innovation, that's who we are, that's what we do. But when you think about innovation, the most successful innovations are what we see in our everyday practice, or maybe what we experience as patients or family members of patients. The innovation cycle is challenging. I mean, I showed 2 steps, coding and payment. There's at least 8 or 9 different steps. FDA approval, going to market, post-market surveillance, et cetera. So it's a long process. At the same time, I think we need to be insatiable in our quest for innovation, our quest for knowledge, our quest for scientific discovery, and our quest for research and education. But I wonder if there's a fourth. I wonder if there's a fourth opportunity that comes before us that we can really capture and that we learn from Dr. Doddard. I already told you he took his third patient, angioplasty, to the top of the highest peak in Oregon. And that's understanding the patient's journey. And look, I'm an IR, and I know you're thinking, oh great, here comes the kumbaya moment. But bear with me, let's think about this from a pragmatic, policy-directed perspective. A group of us at the AMA got together and sort of asked the question. And if we're going to get out there and we're going to advocate for physicians and patients and IRs, and we're going to do this, we might want to have some perspective on how we're viewed by the rest of society and patients specifically. We partnered with Forbes Tate, does a lot of lobbying policy work in the DC area, and we asked them, do some surveys, bring together some panels, give us some feedback on what we need to do. A couple of lessons we're learning. Number one, systemic issues are affecting how patients view their physician. Think about your last trip to the doctor. By the time you saw your physician, you were probably a little wet. Annoyed about the parking, the delay, maybe something like prior authorization, so it's real. But what we're learning from patients is they want this. They know we're well trained, they trust we have procedural skills, they want a strong relationship. They want alignment, especially in spending time with them. They want to feel like you're in their corner. It's meaningful to them. It's what they value. As a procedural face-to-face specialty, this is potentially an opportunity, and if you're wondering where this fits into the digital health universe, let's ask ourselves this question. Because another group of us are looking at this, we're asking ourselves, as these digital tools come into practice, it's kind of a lot of show and tell, right? It's, well, my tool does this, mine does this, mine does this. But let's think about it from a patient care journey. Let's ask ourselves the question, a patient going through an experience, what are they going to see from a digital perspective? We're focusing it largely now on behavioral health integration because coming out of the pandemic, this is a really important challenge for our society. But you could easily apply this to anything we do. Hepatic cellular carcinoma, oncology, et cetera. I'm not going to read every one of these, but notice that we can do all of this from a digital perspective. That was enabling tools, here's care delivery tools. And in doing so, notice what's not there. There's no human interaction. Even the visit is telemedicine. Maybe that's okay, maybe it's not. Maybe this generation coming up is what they want. I mean, my daughter's super digitally connected. She has over 500,000 followers on TikTok. I mean, this is her universe. But where does that fall for us in our specialty? Being, it is quite conceivable that patients coming into the interventional radiology suite, we will be the first human to face-to-face interact with them during their entire journey, and they're going to expect a lot of us. And perhaps that's the opportunity. Let me close with a couple of thoughts. I showed this earlier. I borrowed this from Scott and John. This is our competitive advantage at multiple levels, including clinically, and as I've argued in public policy. But I would make the argument that perhaps we need to make this the quadripartite diagram as part of our competitive edge. Bring in digital skills because it's who we are, it's what we do, it's where we've always been successful. As you look at that diagram, think to yourself, there's a lot of specialties out there that can do 2. There's a lot that can do 3. I challenge you to come before me at this meeting and tell me, is there any other specialty besides IR that has the potential to lead in all 4? Michael Jordan said, it's not enough to know the fundamentals, you have to master them. So the challenge before us might be to ensure that we're the master of each one of these domains. And it takes resources, it takes effort, but if we're gonna advocate collectively at a society level, but also at an individual physician level, we have to be the experts in this. We have to be recognized as the experts in each one of these domains because the opportunities are vast and the opportunities are real. I made this point in my opening. I kind of showed a catchy end slide. I mean, this is us. This is who we are. This is our ability to capture the moment going into the next decade to be the leaders across healthcare, the same way we proved we could do it in the late 80s, and we're proving we can do it at this meeting. It's our legacy. It's Dr. Daughter. Dr. Daughter passed in 1984 at the age of 64. So all of that incredible activity which I described post-1987, he wasn't there to see. But if he were, I can assure you, he would have been remarkably proud of who we were then. And if he were with us today, as proud as we are to be part of his legacy, the legacy that created everything around us, I'm pretty sure that he would be equally proud of where we've been, who we are, and most importantly, where we stand in the future and where this specialty is destined to go.